So these are the equations that you use to calculate the FTE, or the full-time equivalent. You essentially solve for X, and the first one uses the average nursing care hours times the days in a staffing period, which is 14 days because it goes over a 2-week time period, times the average patient census, divided by the hours of a full-time equivalent in 2 weeks, which would be 80 hours, because it's 40-hour work weeks. The other equation that you can use is total nursing care hours times the days in a year, divided by the total annual hours per one full-time equivalent, which is 2,080. And you'll notice in the first equation it says average nursing care hours, and the second one is total nursing care hours. So if you go back to what we looked at in the book, for average nursing care hours, you would use, for that particular equation, it was the 6.19, which is the 161 total patient care hours divided by 26, which is the patient census, to get the average nursing care hours. For total nursing care hours, you would use the 161 in that slot. And then as far as scheduling, there's a lot of flexibility within nursing as far as scheduling. There's anywhere from 4-hour shifts to 12-hour shifts. You can do 4, 6, 8, 10, or 12-hour shifts in order to cover the 24-hour day. And then there's also weekend schedules where you can work 3 12-hour shifts for 3 weeks and then have 13 days off. You can work 6 days one week and 4 days the next week, or you could work a full week and then have a week off. There's just so many different options that you can do because of the way the scheduling and the staffing is within the healthcare system, and you're scheduling over a 24-hour time period. Self-scheduling is very popular. It allows staff to create and manage their own schedule. They post the schedule online so that all employees can see who's working when and when there's available shifts, and they can sign up for their own shifts. Management usually does oversee it to make sure that everyone's being fair, that you don't have the same people with every single weekend off, just to make sure that everyone's working their weekends, and that no one has like a long 4 or 5 day stretch, that it's kind of spaced out. And they also look for like employee expertise to make sure that you don't have all new nurses on one schedule, that you kind of have a mix of new nurses, experienced nurses, and things like that. And shared schedule is actually an interesting type of scheduling, but essentially you have 2 people who split 12-hour shifts. So you might have maybe like 2 part-time people who each work 24 hours a week, but they do 4 6-hour shifts each, and they split the 12 hours. So someone might come in 7 to 2, and then another person does 2 to 7. And then if you ever need to swap shifts, you can swap out the morning for the afternoon and switch with the person who shares the same schedule as you. They use that a lot when they want to do like a consistent schedule, when it's the same every single week. Because with the self-scheduling, you can switch days and work different days, different weeks. There's also open shift management, which is essentially they post open shifts so people can pick up extra hours if they want, and it works nicely because you're using people from your own unit who are trained on your unit, instead of using like outside float pool staff. And it's also nice because it goes in conjunction with the self-scheduling, especially now that a lot of hospitals are doing it online and the whole schedule's posted. People can just go in and pick up shifts, 4-hour shifts here, 6 hours there, whatever they want to pick up, they can pick up. There's also weekend staffing plans. Due to patient acuity, we can no longer staff less on nights and weekends. It kind of has to have the same standards as during the week. However, there are some units. My unit does staff less on nights, by about 2 nurses and 2 techs less. But our unit is a little bit different because we are a rehab unit. So usually we can manage with that unless we have a really high patient acuity. Then we will keep the extra staff. But generally speaking, especially like in intensive care and med surge, you can't really staff less on nights and weekends anymore. So at Baylor University, they developed the Baylor Plan for weekends, where nurses work 12-hour shifts on the weekends, but they're paid for a standard work week. So say you do Friday, Saturday, Sunday, 12-hour shifts, that's only 36 hours, but you get paid for working 40 hours. So that's a way to entice people to want to do those 12-hour shifts on weekends and to pick up the weekend hours to compensate them for it. So, and then another type of staffing or scheduling that we have is automated scheduling. And it's where a computer system contains all the patient information and like patient acuity. They have them ranked on acuity levels. And then it has the nurses ranked in levels of like strength and expertise and experience. And then the system automatically places nurses where they're needed. And then whenever there's gaps, you can fill in with supplemental staff such as PRN nurses or float pool staff, or you can kind of do like an open shifts thing and have people pick up hours that are available. And the book actually talks a lot about using like internal supplemental staff and external and the differences between those. And using internal is using an internal float pool, which is obviously more fiscally responsible because you're using people who are trained by the hospital. They know the system, they know the procedures, they know the protocols. So it's better for patient care, and it's better money-wise because you're using like your own staff. Then external would be bringing in like agency nurses. Sometimes they do that if there are nurses who are on extended leaves, like maternity leaves or FMLA, but generally they try to stay with internal employees. And then you have centralized and decentralized scheduling within that, and like a centralized is where you have float pool staff that can kind of go all over the hospital, and then decentralized is when they only go to particular units, such as like I know Lehigh Valley has their own own intensive care float pool staff, and then they also have their own labor and delivery float pool staff, and they only float between those units. And then you have like the general float pool, and then I think even Muhlenberg has their own float pool. So there's a lot of different options with that. And if there are people who are cross-trained, that allows for more flexibility with scheduling as well. So that's always a bonus if you have people who are cross-trained. This was actually like a handout that I found for safe staffing, and it's the American Nurses Association had it published on their website, and it talks about the Registered Nurse Safe Staffing Act. One big thing with this is they don't declare a ratio because they kind of leave that up to the nurses to decide based on their patient census and their patient acuity as to how many patients a nurse can care for. So they don't dictate patient ratios in this, but they do dictate that there are certain standards you need to follow in order to have safe staffing. And along the side here, it says, research shows safe staffing can keep patients safe. You have less sentinel events and things like that, less med errors, less hospital-acquired injuries or illnesses. And then you also retain experienced nurses because evidence has shown that there's a link between mandatory staffing plan legislation and nurses' perception of a more positive nurse work environment when compared with mandatory ratios or no staffing plans. So the hospitals are able to save money and retain nurses versus spending money to train new nurses constantly if they can, keep their staffing at good levels. It cut costs because you're not bringing in like agency nurses to do jobs. You're using your own RNs. But increasing the number of RNs can yield a cost savings of nearly $3 billion, which is the result of more than 4 million unavoided extra stays due to adverse patient events, such as infection and bleeding occurring in the hospital. So that's a ton of money that you're saving. When you look at it, like paying somebody, a couple $100, paying an additional nurse a couple $100 to work could save millions of dollars or, thousands of dollars from, having the extra staff to prevent all of these adverse patient reactions. And the Safe Staffing Act they actually do it based on a committee of at least 55% direct care nurses who publicly report their staffing plans. So this is actually what I read before in the beginning of the presentation about the requirements by the ANA and the Joint Commission. And essentially, the Safe Staffing Act holds hospitals accountable. They need to establish procedures for receiving and investigating complaints if there are short staffing complaints. They need to work with the Secretary of Health and Human Services to, hand out monetary penalties if there's any known violations. It's a whistleblower protection for RNs. If they file a complaint regarding staffing, they're not going to be retaliated against. It requires public reporting of staffing information. So this is where they're required to report how many RNs they have on that day, how many tech partners they have working, what their patient care hours are, what their nurse care hours are. That's the form that I was talking about before that our unit posts so that everyone who walks on the unit can see what our staffing is for the day. Because that should be public knowledge. People should know how they're being taken care of. And that's pretty much it for that. I'm going to post a link when I post the presentation so that everyone, if you want to go back and look at this further, you can do that. So I'll post the link at the end of this. This was a diagram that I found in one of the articles that I had, and it pretty much talks about how staffing excellence affects everything. It affects patient satisfaction. It affects employee satisfaction. Everyone's happier when they're not feeling rushed to take care of their patients. It affects cost. We just talked about how you can save millions of dollars, billions of dollars from, preventing millions of different sentinel events from occurring. So it's a cost saver. It affects the work environment. I'm sure that everyone has worked on a unit at some point where you're understaffed and stress and anxiety is sky high, and that negatively affects the work environment and the care that people are providing. It affects quality, safety. Obviously we talked about that already, that if there's more nurses on the floor, you're going to have less quality and safety issues happening. And then even greater than that, it affects patient outcomes. Less people are going to have an extended stay if they are receiving proper care. And it also affects business results. Hospitals save money by having some extra staff on the floor. And employee commitment. People are more willing to stay with the company if they know that if they're happy there, they're more willing to stay, and they're more willing to work or maybe even pick up extra hours if they know that they're coming into a well-staffed unit. This was a quote that I found too about innovation. It's saying, let's not let the barrier to uncovering the potential of excellent staffing practices be our own thinking. Approaching the topic of staffing with a sense of inquiry, letting go of mental models and constructs that are familiar and comfortable, combined with a strong understanding of the data, experience, and wisdom available to us will uncover new possibilities. There's so many different types of scheduling and staffing that you can do, and different things work for different units, and maybe none of these things work for some units. So it's really about coming up with new ideas and new ways of doing things, which can sometimes be hard, especially if you have a unit who is maybe stuck in its ways. It's hard to change those things around, but it affects so much more than just the nurses. It affects like the whole big picture. So really coming up with new ways to do things is beneficial for everyone. So this is time for some math. This was a little exercise that I put together to explain how to do the equations. So actually it's going to go into part 3 on this, but you can click through on that and we'll go through this.